Over to you, Dr.
Hi. Hi, good evening, everyone. Thank you so much, Rachna ma'am, for the introduction. Um, as Dr. Vibin already introduced the topic for today, I think it it is a matter of it is a topic of extreme importance right now, since we are seeing so many respiratory tract infections in our OPDs as well as in the ICU. So it only makes sense to discuss about the these infections, how they present, and what are we actually looking at. I extend a very warm welcome to our esteemed panelists. Thank you so much for taking out the time for this special session of BLK TELE-PEDS. So I'll just start with the discussion now. So what are the key objectives of today's discussion? First, we need to figure out whether are we actually seeing a change in epidemiology of the respiratory pathogens? Is this surge really out of the ordinary for this season? What is the clinical profile of these acute respiratory tract infections? What are the complications associated with them and how to tackle them? Then we'll be discussing about the diagnostic tests for various viral pathogens, treatment role of antivirals and steroids, and then we'll be discussing a little bit about the current influenza vaccines. So every year, winter season, in this.
क्योंकि मेरे इस पे ट्रांसफर हो सकता है डेस्कटॉप पे
So every year in this
जूम मीटिंग
winter
करना जरा
season, in the latter part of winter, we see a battery of patients with respiratory tract infections, and this is mainly due to seasonal epidemics
व्हाट्सएप पे
of respiratory pathogens. And the common pathogens that we see, that we are seeing this year as well, are some of these viruses: RSV, influenza, adenovirus, and of course, human metapneumovirus has been in the news. And we are seeing a lot of mycoplasma cases as well. Recently, there was a big hue and cry in media about the human metapneumovirus cases surging in China, and that the hospitals were overwhelmed. And then there was some news in in India as well. However, it was diffused by this statement given by the Ministry of Health and Welfare, where they stated that the surge is surge in this surge of cases in the country is not out of the ordinary, what is seen every year, and they just recommended strengthening of the surveillance program. And then WHO also stated that the the increase in respiratory pathogen detection is within the range for this time of the year. However, I our viewpoint may be different, may not be different. So now I invite all my panelists to please give their opinion. Are we really seeing a surge in respiratory infections, which is out of the ordinary for this time of the year? So first, I would like to invite Dr. Kukreja. So please give us an insight of your experience in OPD and hospital.
Yes, Dr. Ritika, good evening, everyone. And I think we keep on seeing this surge of respiratory infection almost every year, and the bug changes. And one thing is constant. You keep on seeing RSV throughout, and then in between there's a surge of, like these days, there's a surge of influenza B. Sometimes you may see mycoplasma. I think last month we had few cases of mycoplasma, and they were more than what we normally see. And as far as human metapneumovirus is concerned, we do see sporadic cases and admitted with us, and they behave similar to RSV infection. And yes, I think we keep on seeing this surge. And these days we are seeing little more influenza B as compared to other viruses.
All right. Thank you, sir. Dr. Rachna, would you like to add your experience in the pediatric critical care unit?
Yeah, I think I completely agree with Dr. Shyam Kukreja that we do see surge of viral respiratory infections during this year and the bug changes. I think as a BICU person, I would say that we keep on doing like multiplex PCR for many patients, and we would find that RSV will be there, influenza will be there, but the complications will be more with one bug. And that will be scary for, as an intensivist, I would say that will be scary. Like, I think last year we had really good struggle with adenovirus. And this time, I think influenza B is giving us a very hard time along with mycoplasma. So these two bugs are really creating a lot of havoc, and obviously constant. It keeps popping up as encephalitis or as ARDS.
Yes, I agree. Last year we saw a lot of adenovirus, and this year we are seeing more of influenza and mycoplasma. I agree.
All right. Dr. Purvi, please give us your experience in the lab since you're dealing with the pediatric and adult side, and you must be getting a lot of respiratory panel tests.
I think I agree because this time of the year we have been seeing a lot of influenza B, but if you see across over a time period, we have a lot of RSV, the respiratory syncytial virus. I think it's been through the year, and it's around 48 to 50% cases we see are of RSV, followed by adenovirus, which would be around 20 to 25%. But influenza B last year, it was not, we didn't see such a high surge, but this year we have around, if I say around 16 to 70% cases would be of influenza B. And mycoplasma, yes, on and off, we do cases of mycoplasma, but when you look at the number of cases, the percentage would be somewhere around 5 to 6%, not more than that. So I think it's just as Dr. Kukreja said, we have been, we have had cases of metapneumovirus on and off, sporadic cases, and it has been there for long. And maybe 4 or 5 years back, we were actually not looking into this viruses, but right now with the advancement in diagnostics, we have been able to diagnose. And I think that is paving the way for a better treatment and monitoring of treatment as well.
All right, thank you, ma'am. So yes, we are seeing a lot of respiratory tract infection, although the surge is not extraordinary. The organism keeps changing every year. So let's do a quick revision of microbiology of all these viruses that we've been seeing. So influenza virus it belongs to the Orthomyxoviridae family. It is of three types mainly: influenza A, B, and C, out of which A and B are known to cause infections in humans. Influenza surges are seen mostly in late winter to spring. It has two major antigenic components, the H protein or the hemagglutinin and the N protein or the neuraminidase. And it's because of the different combination of these two proteins that the influenza virus is so variable. It has a special, influenza virus manifests antigenic drift and antigenic shift. So in antigenic drift, there are minor changes, minor mutations in the structure of the virus. And that's why every year in the seasonal epidemic, the virus changes and the people have partial immunity to the influenza virus. However, when we see a major mutation in the main virus, where we see a crossover of maybe an avian strain with a human strain, completely new strain is formed, and that is responsible for causing pandemics. So it's because of the antigenic drift that we need to keep revising the vaccine every year. Now, human metapneumovirus is not a new virus. It was discovered in 2001, and it belongs to the Paramyxoviridae family, same as RSV. And it is the second most common cause of pediatric LRTI, second only to RSV. It is a droplet infection, and HMPV infection also peaks from January to March every year. RSV, as we all know, is the most common cause of bronchiolitis in infants. It causes bronchiolitis or LRTI in children less than 3-year-olds. And we see RSV happening throughout the year. However, from mid-October to November and Jan to March are the peak seasons for RSV. A little something about Mycoplasma pneumoniae. Mycoplasma is a pleomorphic organism. That means it is neither a bacteria nor a virus. It does
लो
not
है तो
have
मना कहाँ करता हूँ ये लो
so it
अगर
unlike
अप्रोच है
bacteria, and it can survive without a host cell. So it unlike viruses. What it does is it has a unique gliding motility because of which it embeds itself in between the respiratory epithelial cells, and there it causes cell injury and sloughing. The antibodies that are produced against mycoplasma act like autoantibodies and interact with the RBCs and neurological cells. And that's the reason that we see extrapulmonary manifestations and complications of mycoplasma very often in the critically ill patients. It affects children and young adults. Incubation period is 2 weeks, and prolonged paroxysmal cough along with or without fever is the most characteristic sign. So from our college days, we've learned that whenever the clinical picture of the child does not match with the radiological picture, then we should suspect atypical pneumonia and mainly mycoplasma. So we might have a child who's absolutely stable with just persistent cough, and when we get the X-ray done, he will have a big patch of pneumonia. Then that kind of indicates mycoplasma infection. So to further our discussion, let's discuss a case. We had a 9-year-old girl with high-grade fever, cough, and sore throat since 1 week, and dyspnea since last 3 days. She was taking some supportive treatment at home, but was clearly not responding and landed up in the hospital. On examination, she had high-grade fever. She was sick looking, and she had respiratory distress, tachypnea, and a little hypoxia as well. So she was admitted in the PICU. So now I would like to ask my panelists again that what are the clinical features of acute respiratory tract infection, and can we get an idea of the etiology of the infection by the clinical presentation? Are there any specific pointers? Dr. Kukreja, sir. So you're on mute.
Sorry, all viruses, they look very, very similar in their clinical presentation, and that's the value of having a PCR multiplex test. But I think in clinical practice, you are able to make out which virus is this. I think epidemiology plays a very major role. You are seeing a lot of influenza, and the patients are behaving like influenza. You feel, yes, this should be influenza. Similarly, epidemiology is dengue, you say it is dengue. So I think epidemiology is a very, very important factor, but there are some markers which tell us this which virus is this. For example, if you have adenovirus, the child may have bit of conjunctivitis, and there may be tonsillar exudates. Counts in CRP in adenovirus are something like bacterial infection. They can be raised. Now you have a RSV infection. Mostly it is child less than 1 year who's got bronchiolitis. The fever is usually low grade. There's cold, there's cough is minimal because the bronchiolitis, the bug affects the bronchioles. So the cough is minimal, but the child may have a lot of breathing difficulty. So this is how RSV can present. If you take influenza, there's a rapid onset of high-grade fever. Patient may have chills, severe fatigue, muscle pain, headache, and a very sick-looking child. So this is a scenario of influenza. If you take mycoplasma, as you were describing, it's a classically walking pneumonia. There's a mismatch between symptoms and signs, and you are able to make out if there's an outbreak going on. And then, interestingly, in mycoplasma, the duration of symptoms are longer as compared to other illnesses before the child gets hospitalized. Like the child will not get hospitalized in first 2 3 days, will hospitalized after 7 8 days. And then if you can appreciate fall in hemoglobin or there's a Coombs test positive, all these things, I think they are markers for mycoplasma infection. So there are sorry, few markers which can really tell you, yes, what type of infection you are dealing. I think above all, it is epidemiology which is most helpful.
Yeah, thank you. Thank you, sir. I totally agree. Very soft markers for different infections. So, as per the WHO service case definition, The influenza-like illness is defined as fever more than 38 degrees, cough or
क्या
sore
कर रहे हो यार बैठ के तुम ये
onset within the last 10.
अल्टीमेट है भाई साहब
I think
मतलब
Ritika
बैठ
announced
के
कि everyone should be stop their video audios.
Yeah. And
Please,
case
everyone.
definition of severe acute respiratory infection is ILI that requires hospitalization. However, this definition I feel is very non-specific and vague. It can be used as a screening tool in community programs, but when it comes to our tertiary care centers, then this definition is not sufficient, I feel. What do you think, sir? And you're on mute.
Yes, I think it's a very, very, what should I say? Um, the case definition is not characteristic. I think, but anyway, I think if you have such a case definition, then you can include large number of cases in this.
Yeah.
And even if they are not, but I think this is what the definition for the peripheral worker has to be like this.
Yeah. So I came across this study which was published in 2024 where they compared the clinical features of different viruses. I sincerely request all participants to please mute their sorry about that. Yeah, so I came across this study where clinical features of different viruses were compared, and they inferred that it is very difficult to clinically differentiate between the organisms because the symptoms are a lot of symptoms are overlapping. And the need of hospitalization is almost similar with all except for influenza, where they reported that it was less. But in our experience, we are seeing more of influenza getting hospitalized as compared to other viral infections. So moving on with the case, this child was admitted in the PICU and HFNC was started, steroids were given in view of respiratory distress, and child was in type 1 respiratory failure. She required mechanical ventilation, but she was not maintaining oxygenation, so she was referred to us at BLK-MAX hospital. This was her initial X-ray at presentation, which shows, bilateral diffuse infiltrates, very typical of a viral infection. And these were the investigations that were done at the parent hospital. So my question to you, Dr. Rachna, is can you interpret these reports for us? And what are the possible complications of ARI that we see in our ICUs?
So if you talk about the complications, then I think we all know that ARI is the disease which is mostly managed at the OPD level. However, very few cases, less than 5%, I would say, gets hospitalized, and I think 1% of the cases comes to PICU. Now, if you look at this report, you will see some leukopenia. There is some thrombocytopenia, like platelets are less than 1.5, and transaminitis is there. And there is a coagulation dysfunction. Now, this transaminitis is not so uncommon with any viral illness. Seeing a SGOT, SGPT at the levels of 77, like, around 100, 200, it's a very common scenario. But if you have transaminitis in this range of 3000s or 11, 2000s, then you correlate this type of picture with a severe disease. So basically what is happening in the body, whenever the virus gets in, there is an adaptive immune response is there, and there is a pro-inflammatory cascade. When this pro-inflammatory cascade gets exaggerated and is not controlled by anti-inflammatory cascade, then you see this kind of a storm. And this storm mimics your sepsis-like picture. And that's why you see transaminitis, you see these coagulation disorders. And obviously, the child will be very sick, and these are the children who will have severe ARDS, and these are the children who may present with encephalitis, and obviously the other disorders also. So basically, it is a cytokine response syndrome, I would say. Besides these complications, there are kids who may present with very rare but diffuse alveolar hemorrhage also. And that's a very fatal complications. And we had seen one such child in our PICU, which was fatal for that child.
Yeah, so the common complications of ILI that we see are ARDS, worsening of bronchial asthma. If there is a history of asthma, then the risk of complications is high. Then secondary bacterial pneumonias, which are common in ICU patients. Cytokine release syndrome, as Dr. Rachna already explained to us, and even pulmonary hemorrhage, diffuse alveolar hemorrhage. Then GBS and Rey syndrome can also be seen with viruses. Recently, we had some reports of surge in GBS cases in Pune. And long-term sequelae can be post-infectious bronchiolitis obliterans as well. So at BLK, this child had type 1 respiratory failure and ARDS. We optimized the ventilation, and we tried prone ventilation, and we kept on monitoring the PF ratios. Luckily, she did not require ECMO and she responded to prone ventilation. We continued the antibiotics and antivirals that were given at the parent hospital. She was on peptides, azithromycin, and oseltamivir. So we received her, they had already sent a respiratory multiplex PCR, and we got the report, and her influenza B was positive. And so now we discuss a very important topic here, that which tests are available, what are the molecular tests that are available for diagnosing viral infections, and which test is actually preferred to detect these viral infections. And this question is for Dr. Purbi.
Okay, so diagnostic test, historically, we always had those serological markers for different viruses. Now, and we have been using, mainly we have been using the serological markers for quite a long time now. But the problem with these markers are some of them are non-specific, and they do cross-react with a lot of other viruses, maybe of the same family or similar viral makeup. And secondly, the problem with this serological markers is also that you have to see a rising titer in some of the viruses, but still they do help us in the diagnosis. But in recent times we have been there has been advancement in the diagnostic field, and a lot of molecular methods have come into the come up. And when you have shown a report of a multiplex PCR, yes, I would still say this is one of the best available diagnostic modalities with us, because in a single sample, in a single run, you can know a whole lot of viruses or bacteria or fungal. I mean, like, it depends on the makeup of that particular kit. So it do help us, but at the same time, we have to look into a lot of other things, like usually if we have some kind of multiplex PCR, the cost is a very important factor. So whenever we do order this test, we have to be very specific, and then the kind of patients we're using this test, like the case we had in the discussion. So I think this is one perfect example of a clinical scenario where we'd like this kind of test. But if we have a patient, a child coming to the OPD, and clinically you hint a viral infection, then maybe we can wait and not order such, costly test. Now, and also the multiplex PCR is a very, it's a very, updated and very sensitive method. So, but the makeup would different, like the BioFire that you showed, it had a whole lot of viral and, other things, but there are other panels also which might have a smaller number of, or lesser number of viruses.
So
So
these
that,
panels can be tailor-made by
yeah,
different.
so those are actually tailor-made by the commercial vendors. So
Yeah.
we can use them as we like, as Dr. Kukreja said, that you get a hint on the clinical picture, a little hint that, this child might be having this kind of, the clinical etiology could be this. So based on that, and also the seasonal variation and the local epidemiology, we can actually prefer which panel that we want to use. So we
So
have to be very,
have single-plex
conscious in using
PCRs
this
also
panels, I
available
would
to us.
say.
So do we
Yes.
have single-plex PCRs also available to us, or we only have these multiplex panels?
We have for respiratory virus, we don't have at present in-house. We don't have, but yes, singleplex PCR are there for tuberculosis, for HPV. We have been using singleplex PCR. Singleplex PCR was the one which was traditionally singleplex PCR was available, but now because for singleplex you have to like, okay, look for influenza A, then B, then mycoplasma. So it would need a lot of, test runs. So multiplex helps us in that, in here, that because in a single run with a single sample, with a single kit, you can get the, results for a whole array of viruses or bacteria. So that's where I think multiplexing, I'll definitely, go for multiplexing because, but yes, then you have to be very careful because
Is
there's a
the
costly test.
sensitivity of the multiplex and singleplex PCR?
No, the
What is the
sensitivity
reliability?
sensitivity would be, see, the sensitivity would depend on the make of the kit, you know. So, and all these PCR methods are very sensitive. So when we use them, it would also, the dead DNA would also be tested positive by any PCR methods. So the problem with these kits, I would say, is the oversensitivity.
Yeah.
So there we have to be very conscious about, we have to correlate with the clinical picture and the seasonal variation, the epidemiology, and then we have to use this test very consciously. So that would be my take on the whole diagnostic part.
And ma'am, a little something about the upper airway and the lower respiratory tract panels, because we have two types of BioFire available, the upper and the lower one. So
I would still say don't use the word BioFire because that's a commercial name. So I'd
yes,
still like to use the word multiplex PCR. Okay, so yes, that's the multiplex PCR panel that we have for the lower panel. That's called the pneumonia panel.
yeah,
So obviously the composition of the panel is different because in the pneumonia panel we have like other the bacterial markers are more, like we have Acinetobacter, E. coli, Clab, and Staphanol, and we have mycoplasma also, Chlamydia pneumoniae. The problem, you see, here again, the sensitivity of the kit is so high. So you have to be really careful whether the particular positive bug that has been given by the kit is really causing that disease. Number one. Number two, when for the pneumonia panel, we would take samples like endotracheal secretions or bowel fluid, which would also, the colonized bacteria could also will also give a positive result. So there again, we have to be very careful on the treatment part because sometimes colonization may not need a treatment, whereas over-reporting would also, run into a whole lot of antibiotics being given to the patient. And there can be also variation in the quantitation part because when you talk of pneumonia for bowel fluid or endotracheal fluid, it is always a semi-quantitative a count that tells us whether the bug is only colonizing or it is pathogenic. So there could be some difference in the quantitation between a routine bacterial culture and a multiplex PCR. So clinical decision has to be very correct. So whenever we do the test, not only this one, any test, it has always has to be in concordance with the clinical feature, the radiological features, and the treatment has to be based on that. So these are but beyond that, beyond this disadvantage, I feel a lot of advantages are there because with the advent of this molecular methods, whether it's singleplex PCR or multiplex PCR, we have been able to have this diagnosis. Initially, if you look, when we are doing our MDs, we'd never think about a metapneumovirus or an RSV or an adenovirus.
Yeah.
We'd never have such a
So
diagnosis.
I would like to ask this question to our other panelists, that what according to you is the clinical utility of the respiratory multiplex PCR that we are doing? Are we doing it routinely in the OPD practice, sir, in Dr. Kukreja?
See, these are the tests. They have lot of, they're very sensitive, as Dr. Purbi was telling you. And in my practice, in my OPD practice, I hardly do any test. No test at all. I treat them as a viral infection. Now coming to, now coming to hospitalized cases. Please mute your audio. Please mute your audio.
I request
Dr. Harish, please. Dr. Harish, please mute your audio.
I
Dr.
request
Harish,
Max host people to please mute all the audience.
Dr. Harsh, yes. Dr. Harsh, please mute. I think we organizers cannot do anything. That's right.
It's just muted.
Okay. So in OPD practice, I hardly use these tests and I treat them as a viral infection. You have fair idea because of clinical picture and what is epidemiology going on. And you manage those cases and you treat them because I think the saying that I think if you do the test and all that and manage with a lot of antiviral and all that, the patient takes about 7 days. Otherwise, without them, it takes about 1 week. So that's the saying. So I think it's hardly there's use of any antiviral in these cases. Only antivirals are required in cases of immunocompromised or patient who are very serious, sick, admitted. So no need to do, I think supportive treatment is good enough in OPD practice. Now coming to hospitalized patients. In hospitalized also, I do not do these tests routinely. I only do the test if the child is very sick. So these are the cases I do. And I always look into the pocket of the parents. If they are cash patients and not poor, I hardly do the test. But if they've got insurance and they are affording, I do it. And in the occasional patient, even if the patient is poor, but the child is very serious and the test may help me, particularly if I am doing the test multiplex through the ball. In that situation, I do in such cases. So I'm very use sparingly these tests. Because the reason is, it is very difficult to make out is it an infecting bug or a colonizer bug. So there's a lot of problem. Even if you have a bug, you have to correlate clinically. Is this bug fitting into that? So it is very, very important you do it. And I think these very sick patients who get hospitalized and invariably you have to intubate them. That is the time I think you take a sample, tracheal sample or a deep respiratory sample, and that can be a little more informative as compared to nasopharyngeal. So this is my take on this.
And Dr. Rachna, please add.
So I think I completely agree with Dr. Kukreja that doing it in the OPD patients or even in the ward patients may not give us any advantage. However, if I talk about patients who are coming to ICU and now with the upcoming use of non-invasive ventilation or high flow nasal cannulas, here it's a great, it's a great it gives you a great satisfaction that you are treating these kids and you're not giving any antibiotics to these patients. So when these patients come and we see that there is a viral picture, And if we have done a multiplex PCR, and if it comes out to be a viral pathology, then it's very easy for us to tell the parents that this is what it is, and it is a viral, and we are going to treat it as a viral, and we will not be using any antibiotics. So the use of antimicrobial comes down a lot when it comes to ICU settings, especially. Second, at the same time, as there are a lot of co-infections with bacteria which happens, so one has to be very careful that just by sitting on the report and not treating the patient clinically will not be. So we have to keep escalating the therapies. We have to keep thinking whenever you have severe cases. And then these multiplex PCR, gives us information about Mycoplasma pneumonia also. So at times when you have sent and it turns out to be Mycoplasma, then treating these patients, it also helps us. So again, but the most limiting factor of doing these tests is the cost. So we often end up doing only in TPA patients, insurance patients. And we have to really discuss with the parents if they are cash patients or even if they are, panel patients. So that's all I have to say about biofile. But it's quite.
If I can add, it's important because the reason, as you said, is absolutely correct. It can be a very helpful tool for antimicrobial stewardship.
Yeah.
I told you we had a case, it was a case of nephrotic and had adenovirus infection.
Mm.
And there was one else in the family who also had adenovirus infection and got admitted in the adult ICU. So we were very sure that we are dealing with adenovirus, and this patient is kept on worsening. We did not escalate antibiotics more than ceftriaxone because we were very sure that this patient is adenovirus infection, and we know adenovirus can lead to havocs if as happened in Kolkata.
Yeah.
So we kept on managing this patient with more and more ventilatory support. And the stage came when we thought this child is not improving further. Then we had to decide between IVIG and Cidofovir.
Yeah.
And we never thought that we should escalate the antibiotics. So I
Yeah.
agree with you that antimicrobial stewardship is you can practice if you have the bug in the bug.
Especially
In case of influenza, there's an interesting part. I think if the illness is more than 4 or 5 days, super infection is invariably there. But in case of adeno and RSV, this is very unlike that they will have a super infection.
And one more thing, as Dr. Kukreja pointed out earlier, that biomarkers like CRP will be raised in these viruses, especially, when the child started becoming ill or very sick, then these biomarkers goes up. And at that time, it becomes so difficult. So it really helps you. Especially, last year we see a lot of adeno with very high CRP, and we know this is a time when we may end up using IVIG or Cidofovir.
All right. So, coming back to our case, they'd sent a Mycoplasma IgM as well, which came out to be strongly positive, more than 27. So, Dr. Purvi, what is the role of Mycoplasma serology? Is it a reliable test for diagnosing Mycoplasma? The problem with diagnosing Mycoplasma currently is that either we send a respiratory multiplex PCR, which is extremely costly, or we treat it clinically. So, is there any role of Mycoplasma serology in the diagnosis?
See, historically, because mycoplasma doesn't have a cell wall, and it is not something we can culture it in a routine lab like ours. It is hardly any, someone would be doing it only on research level mycoplasma culture. So the alternative was mycoplasma serology. But yeah, like IgM, you look for IgM, IgG, and IgA. But as with other serological markers, there are problems with mycoplasma serology also, because their IgM could stay high for at least a minimum 1 year. And IgA also has been found in, healthy donors, blood donors. IgA has been found to be positive in healthy blood donors also. So it is difficult to rely absolutely on serology. However, you can have a combination of IgG, IgN, IgM, and that too in titers. You can have them over a period of time and see if there is a rise in the titers. That can help at some point of time if you don't have any other modalities of diagnosis. So that's it. But when you have something like the BioFire, or even if you have a single plex and you strongly suspect mycoplasma, then maybe you can go for a molecular method that would be better modulated than the serological test.
So, just to be here, the patient's mycoplasma pneumonia in a multiplex PCR was negative.
Yeah.
This
Oh,
might
yes.
Patient's mycoplasma PCR.
Probably then this could be a false positive, because again, as I said, I think in the beginning that mycoplasma also cross-reacts with a lot of other viruses. So for viruses, there are some which will cross-react. That problem would always be there for the markers. So every test would have its advantages and disadvantages. So
The other factor is, Dr. Ritika, is that mycoplasma IgM can stay positive for 6 to 9 months. So this is one. And two, if you do PCR in that situation, even it is positive, you may not know this is colonizer or infecting agent. So ultimately, if my IgM is positive, PCR is positive, and the clinical picture is matching, so all three match, then you can say most possible probably you are dealing with mycoplasma. So it is not an easy diagnosis in practice, and there are very classical findings of X-ray features of mycoplasma. So you have to combine everything, and then you can make a clinical picture. And then I told you, and these patients normally come after 6, 7 days. They don't come on day 2, day 3, day 4, because this is a illness which is of a gradual onset. It doesn't produce suddenly a cytokine storm. It gradually and slowly builds up. So that's the reason you have to fit it into the clinical picture, and then these tests are positive. Then you can say, yes, most possibly I am dealing with the mycoplasma. And if you have a tracheal aspirate or ball, which is again showing ball, then you can be further confident, yes, this is mycoplasma.
Yes, so basically the point well taken. So for mycoplasma, serology is not 100% reliable. We have to first clinically suspect it. Only in the clinical scenario we should try to fit these tests for diagnosis of mycoplasma. So came across this study where they compared, where they retrospectively analyzed the respiratory multiplex PCR of 3,400 kids who were admitted in the hospital with viral RTIs, and the meaningful conclusion from the study was that children with multiple infections, more than 2 viruses, had significantly bad clinical severity scores. So I would want the panelists to discuss this as well. A lot of times we get multiplex PCR reports where multiple viruses are positive. So how do we interpret these reports? Do we act on it? Does that really help in the management?
I think there are few are colonizers which are there, because when we started getting this multiplex PCR, to be honest, we had no idea what is going on, because there were 2 or 3 viruses coming, and then gradually and slowly, I think we started discussing with other experts, and we came to know that a good number of them are colonizers. But if you have influenza, parainfluenza, you have RSV, and you have a human metapneumovirus, and maybe sometimes adeno, you tend to trust that most possibly these are the bugs which are causing the infection. But I think if there's a ball sample showing the same thing, then you are further confident. But other viruses like rhino and other viruses, they may be colonizers, and so that's how we take it in our picture. Again, I think whatever you get in multiplex, kindly correlate with your clinical picture.
Yeah, that's always been. So like with the local epidemiology, we decide yet this is the bug which is responsible for this clinical severity. So we discard the other virus as being, co-infection and not being so bad.
Bystanders.
Yeah,
See,
bystander.
the
Intro is something which you get every time, you know. Doctor, we went and discussed with Dr. Purbi also.
see there's a beauty in this test, but at the same time, there are the disadvantage is the heightened sensitivity of the test is a disadvantage. And especially if we have a sterile sample like a CSF, we can still we are like sure of the the result. But when we have something like a respiratory isolate, there could be multiple colonizers, so that is one of the disadvantages of this kind of molecular test. Not only the multiplex, any molecular test, because of the increased sensitivity of the test. So yes, everything has to be has to be corroborated with radiological and clinical findings. You cannot just treat the report, you have to treat the patient.
Yes, yes. Great. So to summarize the last part of our discussion, the clinical utility of respiratory multiplex is mainly in hospitalized patients, that too ICU patients who are severely ill. It really helps in de-escalating the antimicrobials in while managing patients in the PICU. It helps in detecting co-infections, and it does help in deciding about starting antiviral to some extent. For atypical bacterial pneumonias, Mycoplasma and Chlamydia, as well as pertussis, respiratory multiplex PCR is the only sensitive test that we have. And in the setting of an epidemic where we have to report viral infections, viral RTIs, multiplex PCR is indicated. And the main issues with multiplex PCR, as very beautifully explained by a panelist, the reliability, we should rely on the report in keeping in mind the clinical scenario. It is very important, especially when we get multiple viruses that are positive. For bacterial multiplex PCR, which is there in the pneumonia panel, the specificity is very low, high chances of contamination and high chances of the positive organism being a colonizer is there. Therefore, even in BAL cultures now, we don't, at our center at least, we don't send respiratory multiplex PCR even in our BAL samples, unless we are strongly suspecting mycoplasma. I think that's the only indication where we really send a BAL sample for biofire. And definitely cost is a big factor. It is an extremely expensive test. So the cost and benefit of the test is still, we have to really justify the cost benefit ratio before ordering the test. So what is the role of antiviral drugs in influenza-like illnesses? What are the clear-cut indications of oseltamivir, and how often are we prescribing it? First, I would like to ask Dr. Kukreja, in OPD practice, do we give oseltamivir?
Uh, I don't give it unless the child is immunocompromised. I don't give it, to be honest. Even in hospitalized who are sicker patient, I only treat of these cases. I think the efficacy is very good in first 48 to 72 hours. But the problem is if they get hospitalized on day 3, day 4, even then you treat. The reason being that you feel it may help a bit, but it's very effective, supposed to be more effective if it is given in first 48 to 72 hours. And if you believe this is influenza, even if the tests come negative, please complete the course because the sensitivity of these tests is not great. They may be false negative. So it is better to complete the course. But if the other virus comes, for example, RSV comes and others come, then you may stop it. But if you are not getting any bug, then in that situation, complete the course. And this is what I think you want to convey. The peak of viral replication is there in first 24 to 72 hours. And that's the key period to inhibit the process. But anyway, I think if the patient comes little later, we do treat with oseltamivir.
Okay, and what about in the ICU patients, ma'am, Dr. Rachna?
So actually, I think I completely agree with sir. I don't have much faith in using these antiviral drugs because we all know we say that they are most effective during first 72 hours. However, whenever these children are getting hospitalized, now there is an epidemic of this influenza B is there, and oseltamivir may be helpful. So even on day 4, day 5, we may start, but again in a sick patient. So even in a very mild bronchiolitis, we can easily withhold and may not start the children oseltamivir. But uh, uh, but whenever you are dealing with the little, you're skeptical that it might help. So I think we do end up giving oseltamivir. Now, rest of the medications like adeno and all, obviously in a very complicated cases or in a immunosuppressed patients, then only we use antivirals like cidofovir and all. Cidofovir was once used by only bone marrow transplant people. We, as a ICU person, have, I think in my last 20 years of ICU, we have used cidofovir for the very first time in last year only. Otherwise, we have never used. Adeno was so less virulent. So one has to be very mindful of using it. That's what. One more thing about, I just wanted to add amantadine. This is just specifically used for influenza A, not for influenza B, because of the change, some molecular change in the makeup of influenza B virus.
Yes, so amantadine is a M2 protein or M2 proton blocker, and it is specific for influenza A only. But there is an increased global resistance to amantadine. That's why it's not used anymore. Oseltamivir acts on both influenza A and B, and so the recommendation right now is that when we classify the influenza patients into Cat 1, 2, and 3, Cat 3 being the most sick patients who are hospitalized, maybe in the ICU. In them, oseltamivir is indicated. Category 1, where the patient is not sick, just has mild fever, sore throat, oseltamivir is not recommended. And category 2 is kind of a gray zone where um, where the recommendation says that you may start oseltamivir, and actually this category 2 is the confusing part where we don't know whether we should start it or not. And sir, I would also want I would ask you to add something about prophylaxis to family members or contacts for with oseltamivir.
I think only to contacts who are immunocompromised, I'll only give it to those. Absolutely. I think if you misuse the drug in that situation, resistance to this will also come. So
Yeah.
only use it immunocompromised. I think we earlier, I think when the H1N1 started, I think it
Yes.
was used a lot in all contexts, family context. Then we learned this is not a huge benefit. And I think most experts all over India, they are only using for category 3, or they are using for immunocompromised children, and that is category 2B, and they are using for those cases. And very sparingly people are using for family contacts whom they feel they are very immunocompromised, very elderly patient, and you are really worried they have a COPD and all those things. You are worried they should not get influenza. So this is how it is practiced.
Or
In fact,
Hey, Rachna, any difference of opinion here?
No, I completely agree with sir. I personally think that one should not use antiviral like anything. Uh, like we are saying that it should be used in category C. Then what is the point of using it as a preventive therapy?
in fact, Dr. Rachna, if you remember, like years back when Dr. Kukreja, as Dr. Kukreja said, when H1N1, we had that H1N1 thing. So it was used as used to give it as a prophylaxis to the staff also. So, but, uh,
So following which we have a lot of gastritis issues.
yeah, but now it is no longer used routinely as a prophylactic.
All right. And so we're at the last part of the presentation. So for prevention of influenza, we all know there's an influenza vaccine. Dr. Kukreja, this question is solely for you. What are the strains, which strains are present in the new influenza vaccine? Why do we need these revisions every year? And what is the efficacy of the vaccine against influenza B?
See, the new strain, for example, now the Yamagata strain is not circulating since March 2020. So now I think FDA has told for 24 25 session of influenza vaccination, it's better to use trivalent vaccine. So they are going back to trivalent vaccine. This is one information we have. And yearly revision is required. As you know, this virus genome is very, very unstable. It keeps on having this thing drift and shift. And that's the reason drift is there every year. And that's the reason influenza is very notorious for that. And that's the reason we need a vaccine every year, new one. Now, coming about the efficacy of the vaccine, it is not a very efficacious vaccine. I think if the everything is okay, like for example, there's no mismatch, age is given in the age group more than 5 years and not elderly. The group we have the best immune system 5 years to say 50 years. So the efficacy is only 50 to 70% for H1N1 and influenza B. But we have no other solution. That's the reason it's being every year. But one thing is definite, and that is it prevents serious illness, hospitalization, and many authorities say don't use everywhere and use it only in cases who are really high risk cases. So that is the logic behind it. And the countries who can afford this, they are using in all age groups. What's the efficacy of influenza B? It is about 50 to 70%, same as H1N1. The efficacy against H3N2 is less. It is to the tune of only 10 to 40%. This is the latest WHO paper on that. And the reason is because this virus, out of the three, is most mutating. By the time you have the vaccine, the virus has further mutated, and some degree of mismatch appears. And that's the reason it is not very effective against H3N2. And what are the current recommendation for children more than 5 years? Our ACVIP recommends that it should be given only to high risk cases. But in our practice, if the patient is demanding, we give it to all age groups. We do not deny it, and I'm a proponent of using this vaccine for all age groups because I feel many times the children fall sick during their exam and all that. Why they should suffer? If they can afford, they can afford this vaccine. But there's one group which is the poor patients, those who cannot afford. I don't insist upon those.
So,
Anything else?
I just wanted to, actually, I just want to ask Dr. Sham, like this time, the age group which we have seen, the age group which was admitted with us with influenza B, it was age group beyond 5 years, mostly
Yes.
very sick patients, 7 years, 8 years, 10 years, 12 years, 13 years. So this is the age group where the flu vaccine might not have been given in most of the cases because the parents are going for the vaccination till 5 years of age diligently and then later on they don't go. So do you think that recommending, yeah, giving a vaccine every year to this age group uh, will become useful, especially in the epidemiology, this kind of?
As I told you, I'm very keen to give influenza to all age groups, but the limiting factor is again a cost. And I'm very keen to give it in all age groups.
Every year.
And, and I take it myself every year for last so many years. And it's very effective against influenza B. Many people may believe it is not so much effective against B because influenza B doesn't go so much of drift as compared to influenza A. The genome of influenza B is a bit more stable than influenza A. So I think it should be given to all the children, even after the age of 5 years. This is my take. And I think guidelines are meant for most population. They
Yeah.
have to consider the population of government hospitals, the population of government dispensaries, and all that. So I think in our private practice, if the patients can afford our consultation of 1,500 rupees, they can really well afford a vaccine of 1,500 rupees as well.
Yeah,
So this makes a good economic sense to give them a vaccine.
that's true.
I totally agreed, sir. So, since we have already overshot our time, I'll quickly give the concluding slide. Respiratory infections do surge in winters due to seasonal epidemics. Unusual complications with subacute respiratory infections are now being identified early, like CRS, as ma'am already explained. Respiratory PCR test may be useful in children with severe disease who are requiring hospitalization. Antiviral drugs for influenza must be used with caution. They're only recommended in Cat C patients, and that too children who are severely sick. It should not be misused in OPD. And vaccine for influenza is recommended in less than 5-year-olds, but not yet for more than 5-year-olds. The efficacy is not the real efficacy is not 100%, but it does help in reducing the severity of infection um, if the child is vaccinated.
In fact, Ritika, the efficacy is more after the age of 5 years.
Okay, all right.
Actually, for the vaccination, though WHO has recommended exclusion of the Yamagata strain, the trivalent vaccine is still, this is the vaccine which is still available. Even this year we have given the quadrivalent vaccine with the Yamagata strain. So, again, I think it's a good point to vaccinate because that would, at least it would decrease the severity of the disease. So vaccination should be there, I think, yearly.
All right. So I would request the panelists to give their concluding remarks, please. So, Dr. Kukreja.
I think let's start with Dr. Purvi. She has been quiet for some time.
Okay, so I think first I would like to thank the pediatrics department for for this for this discussion. It's a very pertinent discussion at this point of the year, and we have seen a whole lot of respiratory infections in both adults and pediatric age group. And this time, interestingly, the focus is on influenza B. And yes, testing, if you talk about the diagnostic part, as I always say, we have to be the concept of diagnostic stewardship has to be very strong. Just because a test is available on the panel, we should not order it. We should look into the case as a whole, the clinical picture, the radiological picture, and whether we really need that diagnostic test. We need the diagnosis, but whether we really need the test or not. So, the PCRs and all, I think, depending on the clinical severity, we should judiciously use this test. And I would just say again that we have a wonderful pediatrics department at BLK. And nice to know you, sir. And Ritika, I think I have met you for the first time.
Yes, ma'am.
So that's from my side.
Thank
That's because we shifted to the other building.
you.
That's the sad part, I suppose.
All right.
I think the good part is we are able to know what the bug is. I think about 10 years ago, we were not knowing what the bug is. And that was a very difficult time. I remember during my secretaryship of IAP Delhi, I wrote an editorial that we do not know what is circulating, and there was no way we could know those days. So it is very good that this we can know the bugs. One, we can treat some infections, particularly the influenza one, and third is once you know this, what is going on epidemiology, you become little more confident in managing, and this really is helpful in antimicrobial stewardship. So these are few points, and I think there's a need to have these tests cheaper and cheaper. Like
Yeah.
COVID test could become available in 800 rupees. So I spoke to, I think, once my friend Dr. N.K. Arora, and he told me that I think a lot of companies are making these PCR kits, and there's a need to have a reliable PCR test because many tests are coming and we do not know what is their reliability. And he was saying they'll be become much cheaper, and they can also we as clinicians should force our administration to use a simpler, cheaper, I think cheaper test. For example, Chennai people are using RSV antigen test, and they have compared with PCR, it is as reliable. And that test I think cost around 500 rupees. Dr. Bala was telling me. So I think we need to have these innovations in our system Because once you know this is RSV, and then you become confident of not giving antibiotics, again useful for antimicrobial stewardship. So all these things need to be done, and I think very nice you raised this discussion today, and thank you very much.
Thank you, sir. Ma'am, Dr. Rachna, your concluding remarks, please.
Dr. Purbi and Dr. Kukreja have said almost everything. But I would say that as an intensivist, I could see what change it has, like what change these multiplex PCRs have done in our practice. Initially, everything was bacterial, but nowadays we are very wiser with these tests coming up. It is much easier for us to manage these cases, especially when we recognize them as severe viral infections, because initially everything was sepsis and CRS was sepsis, but now we know that viral diseases can also be very menacing and very bad.
Severe.
They have been very helpful, especially in antimicrobial stewardship. I think we are very confident in managing these cases without any antibiotics, and I do feel very proud of it that we all have contributed in decreasing the use of antimicrobials, especially in PICU.
In fact, when we first started this test, there's a lot of hue and cry about it, but then I think we did a good thing there. Like Dr. Rachna was kind of like always believed in this test, and I think it has helped to help in antibiotic stewardship quite a bit, at some point of time. So you have to be really judicious while using this and use them wisely. So it does help, but then obviously there would be disadvantages as well.
I think at the end of
I think
the clinical scenario.
before we close, Dr. Ritika,
Yes.
you may find out if there are any questions in the chat box or somewhere you can answer
So
those.
there's one question in the chat box. They say that category 2A patients can also be given oseltamivir as per the recommendation. So what is your take on that, sir?
Category B1. Category B1.
Category B1, sorry.
I think there's no need for that, and I think the new recommendations do recommend not to give it. And I'll say it's better to avoid and use it only in category 3.
There is one more question, sir. And there are getting patients with severe pneumonia, type 1 respiratory failure, blood test showing leukopenia, thrombocytopenia, raised transaminases. What bug may be suspected?
I think it could be influenza virus, which is very notorious to lead to low count as well as thrombocytopenia. And if you are thinking of bacterial in that case, it could be sometimes it could be MSSA or MRSA with the PVL producing bug, which can lead to this type of a scenario. So it is very necessary, I think, to know the bug and treat at this moment is a serious patient. Treat with the broad spectrum antibiotics and maybe oseltamivir, and you can narrow down your antibiotic therapy after you know what is the bug.
So I would just like to add here that all the influenza B sick patients in our ICU, we have seen leukopenia, we have seen counts as low as 1,000 and thrombocytopenia also. So the more the counts are low, severe is the infection. So in fact, we had one case of enteric fever along with mycoplasma with count as low as 600. Like I have not seen counts as low as 600 in enteric, and we were wondering what has happened. And then finally, we were able to find out that child was harboring another bug that was mycoplasma. So here in today's epidemic, I could tell that if you are seeing leukopenia goes more in favor of influenza B as compared to influenza A. In influenza A, you don't see that much of leukopenia. But one should suspect, like in COVID, we were doing the same thing in coronavirus. Whenever these counts were low, then we were worried.
So there's one participant, Dr. Vipin. I think he's just raised his hand. Do you want to ask something? You can unmute yourself and ask a question if you want. Or was that by mistake? Okay. I have a question specifically to Dr. Purbi. Ma'am, regarding the samplings that are done for the multiplex PCR, there are two things which we do. One is a nasopharyngeal sample, and the other is a lower respiratory tract BAL. So, what if we take a lower respiratory tract BAL and send a test for to check the panel on the nasopharyngeal like panel? Is that
See,
reliable or is it not
no,
recommended at
no.
all?
See, the thing is, when we talk about the viruses, the upper respiratory virus, the nasopharyngeal area holds the highest. The population is very high in the nasopharyngeal area. So, and sometimes, so that is why for viral infections, we usually prefer the upper respiratory, the nasopharyngeal swab. Now, when we talk of pneumonia, the etiology might be a bit different. We can still run the test, but the etiology would be different in both the cases. Sometimes some of the virus may not have a very good, population deep down inside the lung tissues. So the population in nasopharyngeal area is more. That is why for viral infections, this one is more preferred. The test can be run, but then obviously the etiology would be different because both the
So I
panels
have a
would have different bugs on the panels.
So if I have a patient suspecting to have a severe viral pneumonia and ventilated, so you suggest that if you're suspecting a viral pathogen, it is better to send a nasopharyngeal swab in that patient rather than sending an endotracheal bile aspirate for the
Yes,
respiratory
yes,
panel. Is that
yes.
right? Okay. Thank you. So I think we have no further questions, queries
I
here.
have one question.
Yes,
Yes,
yes, yes, please.
Uh,
Yes, please.
am I audible?
Yes, yes, you're audible. Please ask.
Yeah. If we order all the three PCR multiplexes like viral, bacterial, and fungal, what is the cost of total all the three separately and individual combined? Multiplex PCR for viral, bacterial, and fungal. Cost of investigation.
Dr. Purvi, would you like to answer this?
I think the cost, I cannot give the cost because the cost would differ from different organization and different places. So it would not be right to, put a number here.
And my second question was that why don't the government comes out with the epidemiology? They have ICMR, All Institute of Medical Sciences, and other premier institutions which can really guide us about the circulating pathogen in a particular season.
See, I think they do have some kind of data available on the NCDC portal, but not in real time, I would suppose. There are a few notifiable diseases which they do, have some kind of data available on the website, but at the NCDC website. But again, like the COVID times, we had the COVID meter running. So, but I don't think in real time that's very helpful. Like you would not have something right now. You would not have something like what is circulating at this point of time. So because they will be collecting the data in real time and the data will be available at a later point of time. So for them also to do it, I think is difficult. But yes, you can get an idea when you go through those websites of ICMR and NCDC. They do have some data available on the current, the past seasonal variations that are available in the country.
From which site we can get?
NCDC.
NCDC. Okay. Thank you so much. Thank you.
So we have one last question. Dr. Vipul has mentioned that there has been management guidelines category based of H1N1. So is there any revised advisory guidelines on influenza after 2019 advisory of Ministry of Health? Any idea about this, sir or ma'am? Kukreja, sir, any idea regarding this?
I was just not very sure about it. So I can have the email and I can answer this question later.
Yes, sir.
Ministry of Health just few days back, because based on this metapneumovirus, they had given this advisory for ILI and SARI. It's
Yeah.
the same that Ritika has put in the slide. So, but then again, I think it was just a precautionary measure that was taken. So, I think Dr. Rachna was there that day in the meeting we had.
No, I
No.
would.
Okay, so the Ministry of Health, they have given in writing that all the cases for ILI and SARI should be notified to the government, and all kind of precautions should be taken, and that's all. I mean, like abhi tak itna hi hai. That is all they have said, and nothing came up after that, I suppose. I mean, like, I'm not aware.
Strengthen the surveillance program
Yeah,
in.
so that's the reporting part that we have to do for ILI and SARI. I think that is all that we have till now.
Yes.
I think I
All
think
right. I think
uh, Dr. Vipul is asking about the guidelines for influenza. So we'll look into it.
I'll wait and find out.
Okay, I think that is the end of the discussion. I think there are no further queries here. So I would like to thank all the panelists, especially for the expert comments that have come across during the session, and also thank Dr. Ritika for wonderfully moderating this session. And it has been a very useful session, and we would like to have many more in the times to come. Thank you so much, everyone, and have a good night.
Thank
Thank you.
you.
You
Thank
so.
you.
Thank
Good
you.
night.
Good night.
Thank you. Good night.
Thank you.
Night, Jay.